Hello, everybody. A warm welcome to yet another episode of the 4D program, Detailed Discussion and Dialogue for Indian Diabetics. We understand that diabetes is not just a single disorder. We are understanding more and more complexities added to it. There is an interdisciplinary involvement that stands at the forefront of management for people with diabetes. And we hope to have a very spirited discussion on the topic, that is heart failure, chronic kidney disease, and diabetes. Where do the guidelines converge? Because there's a plethora of guidelines coming in from all the societies, whether they are diabetes societies, cardiology associations, as well as nephrology. But we'll try and decipher how these are interlinked and what are the commonalities that would ultimately benefit the management of patients under our care. So we have a very esteemed panel of guests with us, and it's my pleasure to invite all of them. Dr. Raja Ramesh, he is a DM endocrinology, DM cardiology, FSCAL, FAP, SIC. He's a senior interventional cardiologist and structural heart interventional specialist from Aster Ramesh Hospital, Vijayawada. Warm welcome, Dr. Ramesh.
Yeah, thank you.
Along with him, we also have Dr. Ramesh Yelanti. He is a DN, senior nephrologist and transplant physician, again working at Aster Ramesh Hospital, Vijayawada. Warm welcome, Dr. Ramesh Yelanti.
Thank you, ma'am.
Really lovely to have you here. And our third panelist, Dr. Rakesh Boba, he is a senior endocrinologist with a degree in DM endocrinology, again working at Aster Ramesh Hospital, Vijayawada. Welcome, Dr. Rakesh.
Yeah.
Very interesting thing. Yeah, what I'm noticing in this is that all of you are from the same hospital, I believe, and everybody has a word. The name starts with R. Was this some kind of a coincidence, or is it like a strategy for keeping doctors that you have to have R there?
Yeah, our hospital is also Ramesh Hospital.
Ramesh Hospital. So yeah, really lovely to have you all here. So just to set the ball rolling, there's an old story from Zen Buddhism that goes way back. It probably originated somewhere in India. The six wise blind men, and the elephant. So the story goes as that these six blind men have never actually, known what an elephant is, and they happen to hit upon an elephant while walking through the forest. And each of them, now they cannot see what the elephant is, they can touch and feel different parts. So each of them is touching different parts of the elephant. One is looking at the tail and thinking the elephant is like a rope. The other is touching the trunk and thinks it's like a wall. One is touching the legs and thinking it's like a tree. So all the six have different versions of the same elephant. Now, why this story is relevant to all of us, what happens in the end is as the story goes, there's some sort of a fist fight between the six people because they have different versions of the elephant and they think the other person is lying. And when it comes to diabetes, chronic kidney disease, heart failure, possibly we are looking at the same elephant in the room and we are looking at it from a different perspective. But yes, through dialogue, I think we can make a true picture of what the challenges this elephant comes with and move forward. So my first question would be, as a nephrologist, Dr. Ramesh, so what do you think are your priorities in a person who has diabetes and chronic kidney disease, maybe has heart failure in the background? So what are the factors you are looking at?
Usually, basically, CKD is the amplifier for heart failure and also for type 2 diabetes and increasing cardiovascular mortality along with CKD moving to end stage renal disease. So, what we personally feel is like we have to some way or the other prevent the progression to ESRD, and second thing is also to prevent the morbidity associated with it, and also the morbidity of heart failure and CV risk progression. This is the primary thing what we want to have
Right,
as a clinician, what we
right.
want to prevent in a patient. This is
Yeah.
rather,
So I think well put that actually end-stage renal disease can be a real cause of morbidity and also contribute very significantly to mortality. Just going forward on this, do you think there is an association between chronic kidney disease and the risk of cardiovascular disease?
Yeah, independently and on top, even in independent CKD that has a higher risk of cardiac. See, most of the patients in uh, with chronic kidney disease die before coming to dialysis because of a heart failure or because of a cardiovascular mortality. And second thing is, like, when added diabetes with diabetes, this is even more. The numbers are even more higher. So by whatever we are seeing end stage renal patients in dialysis, most of them, they are only 10% of what we see. By the time CKD patients become end stage renal disease, 90% of them die because of heart failure or because of cardiovascular risk only, like atherothrombotic risk. This is amplified because of the CKD and doubling or tripling with diabetes added to it, rather than independent CKD
So
or
these are
CKD alone.
yeah, so they're basically villains going together hand in hand. Uh, I think they really, the quality of life very difficult and
So,
also shorten the lifespan. Dr. Rakesh, as an endocrinologist, what do you think your priorities are in such a patient? Like when they come across, are you just looking at the kidney? Are you looking at other things as well?
No, it's my duty to coordinate between the nephrologist and cardiologist and make sure he gets the all the due care. So usually we have a team approach and team prescription. So we make sure is the patient on SGLT2 inhibitor, whether like cardiologist has started, nephrologist has started, or I should start. So we make sure that patient is on ACE/ARBs, and if his urine microalbumin is higher, whether he is eligible to start newer drugs like Finerenone. So we make sure that the patient gets the complete care, and it's not just about the glycemic control or heart or kidney. We have to make sure that patients leads a good quality of life, and we have to treat all the aspects as a patient as a whole.
So I think the most important point you've highlighted is that dialogue has to be there between the different people. I mean, we're not six blind men just not talking to each other. We are six wise men or women talking to each other, and that probably is what will drive everything home. So, Dr. Raja, as a cardiologist, let's say this person has heart failure. Again, what are your priorities from a cardiology perspective? What are you looking at?
Yeah, yeah. Just now, Dr. Vairamis told that there is an association between heart failure and CKD because 50% of the heart failure patient has some form of CKD, and 50% of the CKD patient has some form of LV dysfunction or systolic dysfunction. So, whenever I see a heart failure patient, the first thing I look into is his serum creatinine and other renal parameters because for me, to start the all the pillars of heart failure therapy, I need a good renal function and good blood pressure. The first thing I look into is what are the renal parameters, whether I can give all my four pillars of therapy. The second thing I look is whether the patient is having diabetes or not. The patient is having diabetes. The first thing then I will look back into the Raki's prescription, whether he has started the SGLT inhibitor or he's giving me the chance to start the SGLT2 inhibitor. So first thing I look into their prescriptions, whether he has already started. Most of the time he will start. Otherwise, I will initiate that starting of the molecule. The other thing, in a kidney failure patient with heart with LV dysfunction, there are limitations for starting me. Like suppose we are not able to give the full doses of renin-angiotensin system blockers. Patient already on dialysis, it's okay, different. Otherwise, if patient on borderline renal function, so I have to choose the molecules. So at the same time, the kidney disease should not progress, so the molecule should be kidney friendly. At the same time, we have to address the heart failure. Second thing regarding the diabetes, we all know it increases the mortality double in both heart failure and CKD. So I think Rakesh will agree with me. Right now, the treating the diabetes is not just the glycemic control or HbA1c or fasting sugar. Since the CVOT outcomes has tried since 2015 or so. So every molecule that we choose, there should be a cardiovascular benefit, especially in heart failure patient. We have to choose a molecule which works both for the heart failure and diabetes. So these are my prospects. Whenever I see heart failure patient, first thing I will look into is renal parameters and diabetic status.
So both the diabetes, the status of the glycemic control also is relevant still. It doesn't go out of the box.
Yeah, not least, not only, so,
Yeah.
but also that.
But it's definitely important. But yes, a holistic management. I think the Steno 2 trial did show clearly that if we are holistic in our approach, we can actually increase the lifespan of an individual by 8 years. And whenever I speak of Steno 2, I often say, you can add years to life, and you can also add years to that life to those years. Like you can give them a complication,
Morbidity, yeah. We'll cause morbidity and mortality. Yeah.
both come down.
Yeah.
Um, so, Dr. Rakesh, so let's say, I mean, Dr. Ajab just pointed out here, and this is what happens between my nephrology friend and cardiology friend also. I'm writing an SGLT2 inhibitor, and then I say, Acha, you go and ask your cardiologist also that this is okay. And the same thing the cardiologist is saying. So, do you think this kind of a conversation is important to increase patient confidence in the level of care?
Yes, definitely. Because like nowadays, patients do have, like, especially diabetic patients have multiple comorbidities. So there will be a number of drugs, because a neurologist would start some other drug, cardiologist would be prescribed one drug. So there will be sometimes duplicating of the same prescription. So it's very important that we avoid same drugs, and SAR may start one like empagliflozin, I may start dapagliflozin. So this confusion shouldn't happen. So that's why we go through each other's prescription, we discuss, and we make sure what's best for the patient. And sometimes there may be a contraindication for starting an SGLT2 inhibitor. Patient may have an active urinary tract infection. So we discuss even that. So why I'm not starting this drug for now. So once we treat the infection, and then we'll restart at a later date. So it's good to have such a healthy discussion so that we don't complicate the patient.
Dr. Amish, coming to you. So when we talk of heart failure and diabetes, even without CKD, I mean, how important is the relationship? Like, how common is heart failure in people with diabetes? Is it like overhyped or an actual real problem? Dr. Ramesh?
Yeah, it's for me, ma'am, nephrology.
Like both are Ramesh. I have to.
Yes, I think it is for you only
Yeah.
because question about renal parameter.
Yeah. See, independent of the CKD, independent of diabetes itself, like what I told previously, it is independently associated with cardiovascular mortality, irrespective of diabetes. So, even these drugs we are starting, even without diabetes, also,
True.
DAPA and this gliptins, we are starting, even without diabetes, also, when there is, especially when there is proteinuria, even AC inhibitors, ARBs, also, sometimes we write these drugs to the patient and they say, sir, I don't have diabetes, like,
True.
so even not only pre-diabetics, even any proteinuric patient, we usually we from the armamentarium of all these drugs, AC inhibitors, ARBs, and the gliptins, we try a combination of drugs based on the condition of the patient at that point. Some patients who are having little fluid load, and we want to use a diuretic, we may be using a gliptin. Some patient, when AC inhibitor, ARB can be used, or then there, that is the time when we use AC inhibitor ARBs. But if there is hypotension for that patient, like, there is a combination of interplay, like many drugs will be there. So we have to choose our weapons correctly to address the problem. So it will not be diabetic patient alone for us, especially for a nephrologist. I don't. It doesn't matter to me whether the patient is a diabetic or not to start a this gliptin or an ACARB. A proteinuric patient itself is an indication for me to start these drugs. So especially whenever a patient, I usually advise, like when I send it to Rakesh, any patient, I just say, ask sir if DAPA can be started. This the same thing goes back again because we want that. I make sure that that is one part of it. Sometimes they are very worried about urinary tract infections, repeated urinary. Even that has been proved not a significant issue when the drugs are started or restarting the drug, unless there is a significant pyelonephritis, severe pyelonephritis, that the patient has gone into sepsis because of that thing. Only in such conditions we do, but small minor urinary tract infections, and most of the urinary tract infections what we are seeing with these drugs is not true to this drug. It may be part of the diabetes or
True.
uncontrolled diabetes that has caused things rather than the drug itself. And moreover, UTIs that have been described are fungal infections mostly rather than any of these bacterial infections like E. coli or other things or Enterobacteriaceae family drugs. We usually want this drug to be on the prescription, whether it is cardiologist who is writing, whether the endocrinologist or we ourselves are writing this. Only thing is we have to be able to coordinate among ourselves so that the drugs doesn't repeat or the drugs are not missed because the other things may come like when I don't write or when endocrinologist, I may overlook that thing. The sir has not written for some other reason. So we it's coordination and the communication between the consultants is essential for that these things.
Very rightly pointed out. I think we all agree. I think SGLT2 inhibitors do remain at the backbone of care for such a population from all perspectives, whether it comes to diabetes, whether it comes to nephrology care, as well as cardiology risk reduction. Dr. Ramesh Shilanti, I'll again go with you. When we talk of nephroprotective uh, therapies and starting from lifestyle, so what do you think are the nephroprotective strategies from lifestyle to pharmacotherapy? So, and how do you decide which level to add when?
So basically, we categorize the patients into two groups actually, proteinuric and non-proteinuric groups when we are usually starting any of the nephroprotective agents. And most of the things which we discuss or which we speak of are for proteinuric patients. Most of the benefits are observed in proteinuric patients, especially the proteinuria that is related to diabetes has been shown to have more significant improvement in outcomes than the proteinuria that we associate with glomerulonephritis. So, usually, whenever we are seeing this thing, we usually uh, 1 minute. పండు కొద్ది స్లోగా మాట్లాడవా so usually, whenever we are using these drugs, we I usually don't start dapagliflozin at the onset. I usually go with AC inhibitors or ARBs, then followed by. But in some cases where I cannot use AC inhibitors or ARBs, like when the serum potassium is escalating or when the glomerular filtration is very low or there is a fall in glomerular filtration with the addition of AC inhibitor or ARBs when there is fall is by more than like 50% fall or when the creatinine rises by more than 50%, then I usually go with DAPA instead of starting with AC. Initially, the rule was like you start with an AC inhibitor or ARB, then add another one like gliptin, or and then followed by phenyrenone or like these drugs. But these are not hard and fast guidelines or rules that this should be started before this thing or starting all of the entirety and then going one in a stepwise. Like it's a instead of a horizontal approach like what we were discussing previously, because that was proven therapies previously, we were adding it in a horizontal way. But now we can go in a vertical way and we can start one of the things which is convenient for us and for the patient. Some patients may not come for monitoring when we start AC inhibitors, ARBs. Some patients may be already on phenyrenone by started by somewhere. So in that places we can choose the drugs according to our convenience and the patient monitoring ability. Some patients somewhere. So I usually when I don't need to monitor the patients or when I cannot monitor the patients, I would go with gliptins. But if I have to monitor the patients, I have to go with like I will go with AC inhibitor service. That depends upon the distance from our place where the follow-up time, all these things will matter.
So it's more
So
of
it's
a
not,
person-centric approach rather than a simple algorithmic approach. That
yes,
we have
yes.
to understand the nuances of the person first and then actually proceed. Uh, Dr. Rakesh, so from a endocrine perspective, our guidelines, there has been a lot of change. I mean, from the last 15 years that I'm seeing, guidelines have been totally overthrown again and again when it comes to diabetes management. Can you shed some highlight on current status? Like does ADA 2025 suggest how to manage people with diabetes?
Sure, ma'am. I think last 10 years has been revolutionary in management of diabetes. And with the publication of a lot of these cardiovascular outcome trials, our approach to diabetes management has been changed. Previously, it's all about like cardiac safety, but now the emphasis or onus is on the cardiac protection. So now the guidelines, they recommend using drugs which are not just safe but also cardiac protective. And previously the approach used to be just lifestyle modification followed by metformin, and go for a sequential therapy depending upon the glucose levels or some other factors. Keep on adding one more drug, wait for 2-3 months and see if the patient gets good glycemic control. Then if not, add one more drug. But now the emphasis is on combination therapy with a lot of trials highlighting we can even go for a diabetics remission, and we have to hit hard and hit fast to achieve good glycemic memory. So we need to be more aggressive in our approach in managing the patients. So instead of sequential therapy, now the onus is on combination therapy. So go for combination therapy to achieve HbA1c, the desired HbA1c level, as early as possible. And with drugs like now, initially it used to be just lifestyle, metformin, and other drugs. Now it's like individualized approach. Do a atherosclerotic cardiovascular risk assessment for all the diabetic patients, and depending upon the risk factors, whether he is having heart failure, CKD, or like risk factors for atherosclerotic cardiovascular disease, choose drugs which have proven benefit. Like if the patient is having heart failure, go for dapagliflozin or empagliflozin, which have shown benefit in trials like DAPA-HF or EMPEROR trials, etc. And similarly, if patients with atherosclerotic cardiovascular disease, choose GLP-1 receptor agonists or like SGLT2 inhibitors. It's no more metformin as the first line therapy. I do see a lot of patients coming to me with prescriptions having sulfonylureas and metformin. Though even they are on good glycemic control, I do tend to change them to newer drugs so that they can have the cardiovascular or renal benefit. And so this is important. Like we have to educate the patient, like their newer drugs which can have not just good glycemic control but also can provide other added benefits like weight management. They can help them to lose weight, and they can help them in controlling their blood pressure, and also they can have cardiac protection.
So I think very important that we have to reassure them that the newer medicines actually have proven safety before they are actually released into the market. Because very often the question that I'm asked, when I'm trying to explain that these are the benefits of GLP-1 RA, these are the benefits of SGLT2 inhibitors, the patient says, like, if it's that good, there must be something something negative about it that you're trying to hide. But I think assurance in a factual, one-on-one discussion is important with patients, trying to explain to them why we are using what we are using and why it is the preferred molecule. And again, I think interspeciality collaboration. So what you prescribe, and if Dr. Raja emphasizes the same thing, then the patient confidence does go up. So Dr. Raja, talking of heart failure, Dr. Anish Ilanti was just talking about, adding one drug after the other or considering adding them all together. So in heart failure, what approach do you use? Would you want to use the ARNI as well as SGLT2 and maybe Finrenone all together, or you'll add them in a sequential manner?
So according to the latest guidelines, so early initiation and initiation simultaneously, there is no more vertical now. It is all horizontal. We have to start all the four guideline directed medical therapy initially only. Of course, if the patient has a compromised renal function and hypotension, we can't initiate. Otherwise, if the patient renal functions are good and good hemodynamics, we have to initiate all the 4 or 5 pillars simultaneously. And first, we have to categorize whether it is a reduced ejection fraction or preserved ejection fraction and mid range. So, in reduced ejection fraction, we know all the 4 pillars like beta blockers, MRAs, gliflozins, and RNA, all are showing mortality benefit. But when coming to the preserved ejection fraction, there are very few molecules which shows mortality benefit. Of course, the gliflozins is the one, and RNA plus or minus. So, after categorizing, so particularly in speaking with heart failure with reduced ejection fraction, now my approach is the patient is hemodynamically stable. Within the hospital itself, I initiate all the four and we call back them after a week to check the pulse, blood pressure, and the renal parameters and potassium, and up titrating the dose or down titrating the dose. So why? Because if you can see from the DAPA heart failure trial, the curves start diverging as early as 28 days. 28 days of initiation. So early the initiation, the benefit will be the more, and preventing the recurrent heart failure hospitalization admissions. Because preventing heart failure admissions itself can decrease the mortality, because with each admission, the mortality will be added. So now my approach is to start all the four.
So I think it definitely makes sense to give everything together. And anyways, you will be starting at lower doses and gradually
Yeah.
uptitrating with
Good.
monitoring some of the agents.
Yeah.
So why, make the patient suffer in the meantime and increase their morbidity? So when it comes to SGLT2 inhibitors, Dr. Rakesh, there are a lot of problems, practical problems. I mean, I live in a state now wherein we are already at 16-degree temperature, and you probably are at 32-degree temperature right now. But yeah, during summers, we do see a lot of genital infections, mycotic infections. UTI, though, yes, it is overhyped, but it does occur. So, what are the practical strategies when you start an SGLT2 inhibitor? How can you minimize the risk of these problems?
So even patients have a lot of apprehensions about this because nowadays patients Google themselves. So as soon as we start some drug, they come to us saying this will cause infections. So is it correct for me? And how sure are you? Should we start? So we have to take some time and counsel the patient at the initial initiation, like highlighting its importance or added advantages, just not glycemic control, but also renal protection and cardiac protection. And by with simple measures like increasing water intake and doing a proper hygiene, like after every urination, cleaning the private parts. By simple measures, they can reduce the chances of this urinary tract or genital infections. And sometimes there will be some problem because most of my diabetic patients may have heart failure, and there would be fluid restriction, like we just restrict the total fluid intake to 1 to 1.5 liter per day. And in such cases, it's a slightly a challenge because patients, we can't tell them to drink more water. So we just have to assure them the chances of infection is very less, and the risks they far outweigh the benefits far outweigh the risk. So it's they must continue the drugs. So by spending some time and highlighting the importance of these drugs, I think we can most of the patients they do accept. And by just saying that they will help them to lose weight at least 2 to 3 kgs, most patients are happy hearing that. Like most of the drugs, they're keep on gaining the weight. But with this weight loss, I think most the acceptance increases among my patients.
I think weight loss is a bigger motivating factor for these agents than is glycemic control or actual control of comorbidities. Because we have patients coming in with requests, for I probably they see weight as a cosmetic problem and really want to get better on that front. But yeah, the benefits in terms of comorbidity risk reduction is huge. Dr. Ramesh Hilanti, when we are talking of the risks associated with these therapies, some of these patients may be on ACE inhibitor or ARBs, or they may be on ARNI, and we are also adding pindrinone on top of it. How important is potassium monitoring, and at what potassium levels would you raise the alarm bells that maybe it's not a good idea to start this drug, or maybe I should stop the drug? And are there certain measures for potassium control that we can follow up?
Usually, that is the biggest problem actually with RNA therapy or ASE, ARB or phenylenone. Biggest problem is not renal dysfunction per se, like not the creatine rise itself. It's a very innocuous thing that will happen. Even if it rises over time, it may come down. But potassium, if it rises in a patient who is already having some electrical disturbances in the heart or some other things, it is likely that the patient may land up in frank failure, or he may also end up with is one of the hyperkalemia related cardiac issues. So usually in a patient who is having a potassium more than 5 or 5.5, usually stay away from starting. But otherwise, their dietary things, I just go through that, and if there is any things like some people are used to eating more and more of bananas, like some are used to drinking coconut water. So these things first I will be addressing those things, and I will ask them to withhold those things, and then if needed, if it is still high, I may add on some potassium binders, like uh, calcium polystyrene sulfonate and all. And once it is brought down to around 5 or so, I may start, usually I will start some of one of these. Here is the time when I would use a combination of therapies. I usually start with this thing. But for gliptins, I don't usually mind. Like potassium is never a problem for me with gliptins, so I usually start with gliptin, whatever the potassium is. But if AC in ARBs, usually I will start only if the potassium is less than 5 or on 5. If it is more than 5 or 5.5, usually I don't start. I usually go for other therapies like first dietary counseling, then followed by any of the binders, and then we start these things. And regarding with respect to monitoring these things, usually once I start these drugs, usually see, I usually check for a potassium within a week, and then if it is not rising, usually I add on, not then itself, but after the next week, usually after the 15th day or 16th day. After 2 weeks, I usually hike the dose. And I usually hike the dose every 15 days, but I usually check, you have to check it every 4 or 5 days, so that we will have some modification in the dosing, and we may reduce or we may add on other dose, yeah, based on this.
I think
But yeah, that is
it's
usually.
vigilance early part of therapy. I think if we are vigilant there, we can troubleshoot a lot of things.
Not vigilant, we may be doing more harm to the patient than doing any benefit. See, idea about giving all these drugs and preventing a mortality may be counterproductive if the patient is not willing to follow you up. So I usually check the patient also. Like if see the patient, he will be visiting you as per your schedule, not per as his schedule. And in fact, if he lands up with hyperkalemia and someone says that hyperkalemia is because of some drug, and if he has no knowledge or if we are not imparted knowledge to him, we will be actually in the trouble for causing that hyperkalemia. Rather, it's an iatrogenic hyperkalemia because of the drug itself. So these things have to be kept in mind when we are starting these drugs. See, whatever drug we are starting, if we are not monitoring, it will be iatrogenic hyperexcess rather than any benefit for the patient, and it may harm the rapport with the patient. Like, in
Very
fact, not just doing good to him, you may harm him initially with hyperkalemia. Later on, you will lose the trust and you will harm him.
yeah.
Both ways, patient is not going to benefit from the armamentarium what we are thinking about usually.
Yeah, I think that is very wisely spoken because many a time, and in fact, any of our patients do this. They'll be regular for maybe a couple of months, then they'll disappear for 2 years, come back with elevated HbA1c, elevated creatinine, and they'll come and say, "Madam, दवाई तो आप ही का चल रहा है." I'm like, I saw you 2 years ago, and this is not my prescription anymore. But yeah, you still have to carry the onus of carrying through their care and see them where they are when they are. Uh,
So
just from the same, tolerance perspective, Dr. Raja, how important is volume status of a patient when you decide what to give, and at what point would you think that maybe loop diuretics can be added?
Yeah. Yeah, whenever that coming to the initiation of this efflogens in heart failure with reduced ejection fraction, first I will try to reduce the dose of a loop diuretic a little, because as you know, along with the diabetes, it is basically a diuretic, the acetyl inhibitor. So I'll try to reduce the loop diuretic. Sometimes I even may stop the diuretic if the patient is not much edematous. I may stop the diuretic. And regarding the hyperkalemia, first thing I will try to sort it out as dietary factors, and then I will check whether I can stop the MRA for quite a while rather than stopping the dapagliflozin, which has more mortality benefit. And then 5.5 is my cutoff. If greater than 5.5, I'm worried. Otherwise, usually I will continue the drug. And the question you asked regarding the volume status. So before starting, so euvolumic, and I will try to reduce the dose of the loop diuretic. If not, I will stop. Make sure he is not volume depleted and go into the AKI. So that we can prevent the raising of the potassium and creatinine.
So I think, yeah, it has to be kept in mind that the volume
Mm, mm,
status also
mm.
is important. And yeah. Dr. Rakesh, we talked about dietary factors which may increase potassium. How common is your patients on those kala namak, setha namak? How often do they take it? And how do you counsel them against that?
So I do have a lot of like patients with heart failure and CKD patients, and the main concern is diet, what to eat. So nephrologist would have advised not to eat most of the fruits. So I tell them only you can eat apples or like papaya or guava, which has low potassium. Apart from that, I think other fruits you're not supposed to eat. again we would cut them off non-veg, so it's not good for their creatinine. So there's a protein restriction. I will tell them to substitute with vegetable proteins like dal, or sometimes they can have an egg white once in a while. So and this salt intake is also a very important part. Most of the patients, they have like salt intake from other sources, not just adding salt. They would take pickles. So South India is famous for its pickles,
Very
and these pickles have a lot of salt content in it. And these snacks which are like numpkins which you use, they too have the preservatives and lot of salts. So I tell my patients to avoid all the old pickles and all these numpkin snacks, and go for a fresh foods like fruits and vegetables. So as the fruits are, like the less chances of having them having preservatives or salts in them, and which can reduce their volume overload. And diet is a very important aspect. Like I would, most of them my patient, I counsel them so that they can lead a good quality of life, because most of them are depressed with these dietary restrictions, having both, like they couldn't eat tasty foods, like with salt restrictions, and with CKD they can't eat most of the fruits. So it's very hard to keep them motivated with the limited food
true.
options. We have to take our time and make sure that they can have a structured diet plan, so that they don't feel missing out on life. It's not just, as you mentioned, adding years to their life. They have to add life to their years.
Yeah. So the quality of life remains primary. And yeah, we're all guilty of, giving a food list to the patients. Ki, ye nahi khana, ye nahi khana, ye nahi khana. When none of us actually sit down and tell patients what they can eat. Maybe the conversation should start from there rather than what not to eat. Because then that builds a level of
My
assurance
make
for patients.
sure, like I would ask like patients' preferences, like, so what do you want to eat? So I would say like it's you can eat them or not. So it would help the patient to lead a little bit happy. He feels happy, like we're taking his considerations. Like
Very true. So Dr. Ramesh Shalanti, regarding fluid intake, how do you decide which patients should undergo what fluid restriction? I think sodium restriction we all agree that all of these patients should have, but what parameters do you consider and how much fluid restriction you would advise? In a person, let's say he has an EGFR of 45 and has already heart failure with reduced ejection fraction.
Usually, I just give like I tell the patient I don't like what you told. I don't restrict the patient or I don't tell what to eat, what not to eat. But I usually you can eat everything except this is my this thing. Usually starting like these things you have to do. The rest of the things you can eat. Any number of times if they ask for that. And second thing is when I am restricting food, I also see whether the patient is malnourished or not. Actually, I don't go by any measures as such, but I usually by physical appearance and whatever appetite they are having, by how they are taking food and what are their physical activities. Usually, though CKD patients they are advised not to eat meat, but vegetarian protein is better than non-vegetarian protein. This is what we fundamentally say. Protein is important ultimately. One patient who is having restricted protein comes to dialysis in a very malnourished state. If he doesn't do well on his dialysis, he is not going to do good on dialysis. The patient who is physically well is going to tolerate the dialysis well. So this is the emphasis I do to patients. Like someone say restricting your dietary protein will reduce your muscle mass, in a way reduces your creatinine. That is not what we want. We want to stop the progression of kidney disease rather than stop the production of creatinine. Our aim should not be to stop the production of creatinine. See, egg white, most of the times I usually don't restrict an egg a day is what I usually recommend because I want the patient to be healthy. So, like what you told, if you restrict everything and he comes to dialysis a bit late, but ultimately he will need dialysis with. So if he comes early to dialysis also, if he is healthy he can tolerate his life years on dialysis will be well. This is what I emphasize that. And regarding fluid overload, usually my prescription contains a loop diuretic, and I would prefer to add a gliptin for all the patients when there is a fluid overload state also. So that and fluid restriction is one of the majority things we add, and potassium containing fruits. I usually ask them like I am also not sure what fruit contains what. There are variety of fruits that are available. I can't remember every fruit which has high potassium. The most common things like banana and this thing, anar and coconut water. These are the things. The rest of the things there are a lot of fruits like recently that. So I usually tell them go put your fruit in the Google list. What are the contents of that food, how much potassium can. So you avoid high potassium containing foods. This is what I tell. I cannot exactly tell which is what because every time previously before this AI and Google, and they used to call us and say like when they were about to eat they said, "Sir, I'm planning to eat this thing. Can I eat?" This is what we used to get. Nowadays, with this availability of internet, now they are just. I usually tell them what to eat, what not to eat. There are certain diet recipes that are available for CKD patients in these things. So, how well to make those things? How so there are some good chefs in my CKD patients. There are some. I usually ask them, "How do you make those things?" Like I usually you can share those things through like off late we are seeing many cooking channels.
Yeah,
I would
true.
say I would advise my patients to start a cooking channel for especially for CKD diets, CKD patients. How to prepare a CKD diet? That would be more helpful if we have this. There are Tara Dalal CKD diet is available. I think it's like there is one book by
Yeah,
Tara Dalal for
yes,
CKD patients.
yes.
Yeah,
Dalal has
those
that.
things. Yeah. So those things will help bring establish rapport, increase your communication with the patients, and also see instead of we are always focused on drugs, patient monitoring, and then long-term morbidity mortality, but we are not communicating with the patient how happy he is with our drugs, how happy with his he is with our. But discussing about diet, their like a little bit of empathy for them will help us bring outcomes. Actually, see, they may not be compliant if you write every drug in the book and then give, but when you discuss with them, they are more likely to be more compliant with the drugs. So for better compliance also we need to speak with them.
Yeah, so I
I
think
mean,
hit the you've actually hit the nail on the head. The person's voice matters the most, and when we understand it from them, what difficulties or what challenges they face in real life, and we work around solutions for them. I think that's really important. uh, and you've also highlighted, I think, one very important point about protein restriction. Indian population as it is a protein deficient population. If you look at the data from starch study, which was not even a CKD population, it was people with diabetes. The starch study pan India showed that our carb intake was 65 to even 67%, and the protein intake was hardly 13% or sometimes even lower than that. So, added to that, the myths and misconceptions that are sailing around that protein restriction will actually give benefits. What we are basically doing is, as Dr. Ramesh said, reducing the production of creatinine, but we're actually not improving kidney function there. So it's probably a misconception that we're just delaying the dialysis a little.
definitely. See, again, we shouldn't be in that frame like protein. Definitely, restrict protein will help the patient in some way, but it should not be for the malnourished population. That is what I see. The protein also, the quality of protein, what you take matters. Is suppose you are taking a protein from a vegetarian source, it doesn't have much effect. Like there are experimental studies where there are individual amino acids when they were injected into patients they had some effects on the there will be a hyperfiltration injury like added to diabetes related hyperfiltration injury. High protein intake also has hyperfiltration. This is especially when we say this thing again we have to emphasize that there are many people who are going to gyms and taking excess protein and they are lining up in renal failure. Like
True.
we have to see there should be a balance of what we are like what we are eating rather than excess nothing less. This is what we have to emphasize on when we are the reason why I'm stressing this thing is the statements are going blind like either
Yeah.
people who are taking whatever they want from our conversations. They will
Yeah.
only chart out what is likely good for them and then they
Very.
will follow that thing that especially if we speak for some time we have four have chatted for something like on protein. If a part of this clip goes, that can be a misrepresentation of whatever we are talking.
So basic thing is somewhere around 0.8 grams per kg per day would be a decent intake for somebody who has established CKD. And for normal people, we can go up to 1 and maybe even 1.2, but definitely not above 1.5 gram per kg per day, because that will increase the load. So just towards the end, I think we have a couple of more minutes left. Let's talk of a hypothetical scenario that we have an elderly gentleman of around 70 years with 15 years of diabetes, right? And the EGFR is around 38. The urine albumin creatinine ratio is 450. And the patient also has heart failure with reduced ejection fraction of around 45%. A1C is, let's put it as around 10%. The gentleman is taking insulin, basal insulin, metformin, and sitagliptin, and a statin plus an ARB. So I would start with the endocrine prescription first of all. Dr. Rakesh, what else would you want to look at, and what would you want to add to the prescription here?
So as you mentioned, like SGLT2 inhibitor, the patient is on SGLT2 inhibitor or not, and what is the weight of the patient? Is the patient is obese or like
27.5 ballpark figure? Yeah.
So because in heart failure patient, usually they have less appetite. So we have to keep that in consideration before starting GLP-1 receptor agonist. We can't blindly start and follow the guidelines and start these drugs for all the patients. We have to take into their weight and their appetite before starting these drugs. So I would go with an SGLT2 inhibitor and combination of gliptin with the sitagliptin. I can reduce the dose if I feel like EGFR is falling, or shift to linagliptin, which is safest in across all the spectrum of EGFR. And rather than basal insulin, I would prefer a premix insulin so the patient can titrate his doses well depending upon his food intake and exercise. And I would emphasize more on like exercise and diet control so that his HbA1c would come at least to 7.5. Not 10 is too bad for his health.
Yeah, true. And you've actually hinted something important, because by the time A1C is 10%, basal insulin alone is usually not sufficient. So a pre-mixed or a co-formulation possibly is a better choice. Yes, we can always assess for GLP-1 RAs. In India, the guidelines do say, DCGI approval is for EGFR 30 and above, but we know that they can be actually used at lower EGFRs also very safely. So from a renal perspective, Dr. Ramesh, what would you want to add to this prescription?
So definitely an AC inhibitor ARB. If it is with the heart failure, the AC inhibitor, I would prefer an ARNI combination rather than ARB alone. And on top of it, if I can add with regular create with monitoring of potassium or this thing, and the progression of renal this thing creatinine, I will try to add a, based on the Fidelio and Figaro trials, I would add a finerenone for this prescription additionally.
Yeah, I think we've covered most of it, but Dr. Raja, any other additional therapies?
Yeah, I'm sorry, in between there was some technical problem. I have attended emergency, so yeah. No, I have.
So we were discussing a hypothetical scenario in elderly gentlemen.
Yeah, question. Yeah, partly. Yeah.
So there is heart failure. There's
CKD, heart failure, and HbA1c is 10.
10%. So
right.
What's your prescription?
Yeah, my prescription. See, I told you all the 4 pillars. Sure, I will start. But as Sir told, it has borderline renal function, I think. So maybe ARNI, I will wait, see the other potassium and other values. But dapagliflozin, it is a renal friendly. Can be started along with dapagliflozin, beta blockers, and other mRNA. Will see the potassium again and decide. So. And we can start the dapagliflozin and then monitor, and if the renal parameters and other volume status allows, then we can think of the ARNI.
True. So I think we've kind of understood that at the crux of it, we are talking of the same drugs from the different perspectives for the same patient. All guidelines are actually in alliance with each other. They're not contradicting each other. All cardio, nephro, endo, everybody is on board together when it comes to patient care.
Yes.
I think had a really fruitful session. In the end, maybe one closing remark from all of you. We'll start with Dr. Ramesh, sir.
Thank you. Thank you.
Maybe one concluding message to the audience, Dr. Ramesh, from your side.
A combination therapies with comprehensive care and communication between clinicians is more important for betterment of the patient's outcomes. So definitely we all have to have one common goal, that is to prevent progression and give quality both together to the patient, which we can only achieve through communication with each other and shared decision making with the patients. This is what ultimately, if we are not discussing all these things with the patient and we are going on adding our own prescriptions, that may not build confidence.
Yeah.
So, and more usage of these drugs, we will come to know how better we are going to bring. See, if we have like if more and more patients are falling into the net, we will know, we will also have more and more benefits where we can explain about these things in a better way to patients, like in the future. So these may become standard. Already they are standard therapies and they are included in the standard guideline. Later on, we also can show large population to the present, like patients who are newly coming into diabetes spectrum. They also can be like motivated to use those things with confidence.
True. Dr. Rakesh, any closing comments from you?
Yes, I think we have to educate the patient about the newer therapies. So most of the patients may not be aware of the newer drugs. So they may be still on older therapies like metformin or sulfonylureas. They would just occasionally keep checking their glucose levels. They may feel confident like their sugar levels are fine and they need not keep on changing the medication. But we know about the back end progression of these both microvascular and macrovascular complications. So our approach should be not just glycemic control, but also to prevent these complications in the long term. So for that, we need to use newer therapies which have proven benefit in halting the progression of these both microvascular and macrovascular complications. So we need to take time, and because sometimes I feel in their busy schedule they would just continue the same old medications. They feel like some physicians may feel like the patient is doing good, so why to change the medications now? Why need we have to again spend some time explain the side effects of this drug, or why the patient may feel like overwhelming? So we would continue with old prescription, but I feel that's wrong. It's as an educated person, we have to make sure that the patient gets the best treatment so that he would lead a healthy and long life without any complications.
So
Yeah, very true. Yeah.
not just patients, we have to educate our own faculty also.
Yes. And ourselves as well. I think patients are the
Also,
great
this
for
thing,
us.
like we are like when any new therapy comes to, we are like more unless we see large populations benefiting, we have that inertia. Like
True.
we are like we
Very true.
ourselves move forward to start a new therapy, or we overlook them because the patient is already having well control, or because of falsely good control secondary to renal dysfunction and all. So we usually overlook those things. So these things we have to educate ourselves, we have to educate our colleagues and also the patients.
Very true. So sometimes we just do things out of convenience, but when in our clinics we have to get out of the convenience zone and come into compassion and competence zone. So we started with the story of the elephant, and we realized that the elephant, we are all seeing the same set of problems in front of us, and we can have a dialogue among ourselves to improve patient care. There's another story in Mahayana Buddhism that's called two wings of a bird. So one wing is the inner wing is competence that comes through understanding of science, but the other is empathy or compassion. That's the outer wing, and the inner wing cannot really take flight without the outer wing. So empathy, compassion, trying to understand what the person needs from us in the true sense, that is probably the way forward to become a good endocrinologist, a good nephrologist, a good cardiologist. So sincere thanks to all the faculty here. We've had a really enlightening session. I think it was a learning experience for me as well. So thank you so much for being with us, and we look forward to maybe meeting and interacting sometime again. Thank you so much, and good night, everybody.
Thank
Good
you,
night.
ma'am.
Thank you. Thank you.